All right, it's just after 7. We'll go ahead and get started. This morning we have Dr. Stacy Chronister giving us a lecture today about home therapy.
Okay, so welcome to Not Your Mama's Home Remedies, an evidence-based approach to non-FDA approved therapies. And this is a lecture I've been wanting to do for a really long time, and I finally begged enough to let someone let me do it. And so this is the trial run before I do it for real for a CME audience. And we'll see how it goes. I don't know how much I've timed it out, so bear with me because I realized that the more I did it, I had a lot of stuff to talk about, and I don't know if I would have the opportunity to fit it all in. So, all right, we don't have a clicker, so I'm just going to have to maneuver this way. All right, so a drug, when it comes through and it is getting approved, has quite the process and quite the life cycle here, right? So it takes about 10 years for a drug to truly go through the R&D process. It, on average, takes about $2.6 billion to take that drug to market, right? And only about 12% of the drugs that start out in initial trials make it through to becoming an approved medicine. So you understand how a lot of what we do and a lot of what we pay for now and the cost of drugs that we currently have actually help to fund the cost of other studies and ones that are upcoming and ones that have failed. And right now we have more than 7,000 drugs that are in this stage of development. So hopefully with this broad scope, we can realize that when a drug gets to your office, you can trust it. You know, you say, okay, if it has gone through all of this, you feel confident with that new medication that just showed up the other day that you can start using it almost right away. But realize that that's not necessarily how drugs were in the past. And that's not really how this process has always been. So through all of this, we can now rely on the safety of our evidence and the safety of the FDA that, maybe there's a drug that should have been passed through, but it didn't because of this little caveat or whatever. But now we can trust that and know that these drugs are as safe as we know them to be. But this screen here kind of reminds me, I think of that Neanderthal human, right? So it started out as a Neanderthal and then it's like a walking human, right? So meds kind of started out the same way. I mean, everything started as herbals and what do we do if we did this and bite on the cork of a tree and that, oh, I have less pain when that happens, right? And then now we've developed it into some studies and we worked it out and we've identified receptors. But we need to realize that just because we don't have somebody who's coming in a cute little outfit and high heels and telling you about a medication doesn't mean that there's other things out there that will work and you just don't really realize it, okay? So I think with all of this in mind, we have to keep several things in mind. One, we don't know everything about medicine at this point. We are still changing, we are still learning. We're learning about new receptors. We're learning about new mechanisms. Heck, there's diseases out there that have yet to be identified or brought together and that we now realize, you know what? I saw somebody 10 years ago that fit this exact pattern. If I had known then what I know now, how would I have done this differently? I mean, just even when I was in medical school, fibromyalgia wasn't even believed to be a true diagnosis by more than half of the doctors out there, right? It was this fringe thing. And now I don't know that med students even realize that that was that controversial. P.S. If you still think fibromyalgia is controversial, you're on the wrong side of the creek and you should leave over already. Okay, that's a little side note. But even our entire profession as osteopaths was actually based at one time in a fringe thought process. So A.T. Still himself was kicked out of the MD profession or told, no, we will not listen to these ideas, these wacky thoughts that you're having about how to treat patients other than the way we are doing it right now with these amazing poisons that we have, right? He was looking for a new way to treat people that wasn't causing significant harm and then branched off into a new form of medicine. So we need to remember that we need to keep our minds open to the idea that that things are changing and constant. We don't know everything just yet. So maybe we should consider using something off-label. First off, I want you to recognize how often you are actually prescribing something off-label already, and you may not even realize it. Up to 1/5 of prescriptions that are written right now are written in an off-label way. So this is actually a screenshot of my Hippocrates from my phone, and you can see what is the FDA approved and then dosing, and then anything that has the little asterisk, you see that? Is actually an off-label use and is not FDA approved. But we have enough evidence out there, because believe it or not, we have a lot of studies out there on drugs used in an off-label way, and we can feel confident about those. So gabapentin has only 2 approved uses. One is for partial seizures. Please raise your hand if you've used gabapentin for partial seizures. Okay, so 1. Please raise your hand if you've used gabapentin for a postherpetic neuropathy. How about neuropathic pain? Raise your hand. Right? Fibromyalgia, raise your hand. OMG, you're just not looking for it. Fine. Alcohol dependence, to decrease those symptoms that you're having. This is all off-label. We're already doing this. Don't get me started on TCAs and how we've been using those off-label since probably, I don't know, the 50s, right? We use it for everything from IBS to headache syndromes. It's interesting. So right now we have some new drugs out, like the injection therapy for migraine headaches. And I cannot get those meds approved unless patient has tried propranolol, unless they have tried amitriptyline, unless they've tried any other SSRI, SNRI, and topiramate. So things like that, that actually, if you look at it, I would be using those drugs off-label for the headache syndrome, but they're making me do that before giving me the FDA-approved one, okay? So just wrap your head around the fact that us using things off-label is not a completely foreign concept. And as physicians, we sometimes have to dabble in this. And this is a quote by Hippocrates of, wherever the art of medicine is loved, there's also a love of humanity. And I love that, because I think majority of us, I mean, there might be one person in this room who went to med school with the hopes of a Maserati in their future. But for the most part, we're caring, kind people who genuinely want to see others improve and genuinely listen to people and want to help them and want to help someone who's in a state of crisis. So if we are in that place, we should start with evidence-based medicine, and we should start with FDA-approved therapies. That is the appropriate thing for these patients, and that is the type of medicine that we use. But what about when it doesn't work? So what about when you have this patient who's coming in for depression, and so you started them on an SSRI, and they don't really get better? Then what? This is where I feel like, as a physician, we truly start to become an artist. And this is where you start to see the art of medicine by using the science as a medium. And we can maybe start to draw outside the lines a little bit, because we've tried drawing in the lines and it didn't work. So let's reinvent it just a little bit. So let's discuss some cool off-label uses that you might not have known about. So today, your adventure begins. Bupropion. I think we all know this, and I think a lot of us know about its off-label uses, but some of them you might not be as aware about. Did you know, fun fact, that bupropion was actually developed solely for the purpose of improving safety and tolerance of other existing antidepressants? It was actually developed as add-on therapy to negate the side effects of current antidepressants. So let's use it. One of the main ways we can use it is to counteract libido, men and women, but patients who are on SSRIs or SNRIs appropriately and are feeling well, but are suffering issues with orgasm, erections, just libido in general, you can actually add on bupropion or Wellbutrin and negate those side effects. That's fun, right? And give them a little dip it, and that's always good. We all know that we've all used it for smoking cessation. That's a way, but you can use it for other addictions as well. So We use it in obesity all the time in the combination with naltrexone, because that's the only FDA approved therapy. It was actually toted for use in obesity as an independent drug, and the drug company got sued like $12 billion, like something completely ridiculous, because they were toting it without that FDA label for weight loss. So now it's combined with naltrexone, and just know we can use it for that. So patients who particularly have food addictions, I've used it in sex addictions. I've used it in alcohol addictions, but you have to really be careful there because of the risk of seizures. And patients, just make sure that you're not using it in anything that has anorexia, binging with it, because of the risk of seizures. Prazosin. Has anyone ever used prazosin for nightmares or seen it used for nightmares? Yeah, it's an off-label use of that medication. So, fun fact, the reason why most people remember their nightmares and don't remember their regular dreams is that you're actually woken up while you're still in the REM stage of sleep. So you're like, oh my gosh, I can still remember a nightmare that I had when I was 6 years old, and I was swimming in the pool. This is my nightmare, by the way. Swimming in my pool, and my nightmare was that I guess we had a party at our house, and the whole pool was filled with floaties, and I couldn't get to the top. And every time I would go through, I couldn't get to, I probably have sleep apnea. So starting as a child, I was suffocating, it turns out. But, you know, and every time I would try to swim, another floaty would move in the way, and I was gonna drown, and I woke up, and I still remember how upsetting that dream was when I was 6 years old. But you asked me what I dreamed about last night, and I'm like, right? So the reason that we remember those is that we're woken up in that REM sleep. So what happens with the prazosin is it actually blunts that startle response, okay? So patients, particularly like your PTSD patients, they might even wake up in the morning and they will have noted that their like bed sheets are kind of wet. They'll note that everything's a little tousled. They'll say, it's weird because I feel like I had a nightmare and I kind of like know that I had one, but I don't remember it. I didn't wake up. And so they therefore were able to make it through there and like didn't wake up and punch their wife. And, you know, I've seen some interesting things in the military. Men need a little bit higher doses. I usually start at 2 milligrams and I tell them to titrate it up. So I say, take 1 to 3 at night. If you're needing more than 3, call me. I'll approve it. I just want to know if you're needing more than 3. But you can go up to as high as 16 milligrams. I'll tell you 6 to 8 is a good sweet spot for most males. Females start much lower. I've made the mistake of trying the same dosing in females and they're like, I couldn't wake up for 3 days. I'm like, sorry about that. So just start at 1 milligram and see how that goes for you first. It's an art. We're drawing outside the lines. It's okay. All right, memantine. I think a lot of you who work with me in clinic know how much I love memantine. I'm using it for off-label purposes because the only FDA-approved use of it is in Alzheimer's. There's only like 5 Alzheimer drugs. Like it is, they have tried so many. I think that they've had like something over 150 drugs be attempted to try for Alzheimer's. And right now, only 5 of them have ever worked out. Memantine's one of them. Fascinating, memantine was originally developed in the 60s to treat diabetes, which like is so 60s. It is, to me, that's like so #Woodstock, because only in the 60s do I imagine them like trying to treat diabetes with a dissociative, and that's amazing. So I like missed out on some fun things then, I guess. So it is, there are so many studies. I mean, you can just pull up memantine on PubMed and you can almost find a study of even a small trial, even if it just has like 40 patients in it, for almost any diagnosis that it's been tried for, and see how it helps. Where the evidence lies is in OCD. I personally have used it in a patient who is autistic, and and if you have a patient who's able to express their mindset with autism, a lot of them imagine it like things just clinging around in there all the time. Every piece of sensory that comes in is another mess that's kind of happening in their brain. They're having a hard time calming things down and separating out what is an air conditioner noise background that we can all zone out, because in our head, we know it's an air conditioner versus this blaring machine in the room, right? Like a lot of times they have a hard time processing that, and the memantine can help with that. So we are talking about an NMDA receptor modulator, and a good way to think of it is very similar to what you would imagine oral ketamine is. So my patients totally love me because I essentially have them on some oral ketamine. I use it a lot in fibromyalgia. So again, ADHD, kind of like we just talked about with those patients who have the anxiety and the autism, like let's just kind of calm things down and see if we can help process those. Fibromyalgia, I mean, I think it's helping with their pain control. It's helping with some of the thought process, some of the depression that's happening there. We know ketamine is great for depression. Memantine is not as good for depression, and so it is not considered like a standalone therapy, but can be added on for depression. I usually start 5 milligrams twice a day and titrate up. But I find that if we go to the 10 twice a day, the patients get a little too activated and maybe a little too agitated. Propranolol, blood pressure med, right? But we use it a lot for anxiety. So you can use it just as needed for that person who has test anxiety, the person who has speaking anxiety. A lot of public speakers actually take a propranolol before they get up and do their talk, because we're blunting some of that flight or fight response, right? You still have your good little sympathetic system. We're just taking it from here and putting a block on it about here and calming you down a little bit so you can think a little more clearly. And it should not make the person, it's not like a Xanax, right? So you shouldn't feel drunk on it. You shouldn't feel weird. You shouldn't be slurring your words. It's just taking you from here down to here. So I usually start about 10 to 20 milligrams. In my PTSD patients, I usually will sometimes even start at 40 and have them cut in half to 20, then go up to the 40. And females, I'll usually start 10, but sometimes I'll do a 20 and tell them they can cut that in half. But what's nice is that they can play with it. It's really short acting. And most patients do just once a day, maybe twice a day, but I give them the flexibility to take it up to 3 times a day. You know what? You know your dad's coming over in an hour. How about you take some propranolol? Because you know every time your dad comes over, you get all worked up and then you get in an argument. And so how about we just don't? How about you take some propranolol and calm it down and not go through this? And what I found is that I've been able to not use benzos in patients by giving them propranolol. Patients are wanting something. It's hard to have a panic attack. It's hard to get in that state. And they want something to help them. And all they know is that they took a bar of their mother's whatever, right? Like, so they just want something. But propranolol serves as that something. And we know it's not addictive, and we know they won't have rebound anxiety from it the way that they would have the benzo. So really safe. I put on here square breathing. I would recommend looking this up, but I talk through square breathing with almost all of my anxiety patients. So if we are needing propranolol, we also need self-modification techniques. We need to be able to teach them to slow down their own breaths. And if we can have them even count, then they can stop spinning out in their head and stop thinking about all the things that they're like all anxious about, and they have to focus and count. By controlling their breathing, they actually are able to self-manipulate their heart rate and bring it back down. They stop breathing off all that CO2 because they've been able to control their breaths and hold it in. And you can actually blunt that panic attack before it even starts, or even after it starts. I think those of you who have run it with me, even in the weekends, you walk in and the patient's like, and they're kind of all panicky. I'm like, stop, hold your breath. Okay, out. Okay, a big deep breath. Hold it. Okay, now out, slow. You know, and you can just sit there and walk someone through right there in the room, calm them down, and once they're calmed down, say, okay, that feels better, right? Now, we need to talk about going home, right? Now that we are no longer having this situation, we can talk about our discharge, right? It's very helpful. Cimetidine, so H2 blocker. Fun fact, Sir James Black, he's a Scottish dude, actually received the Nobel Prize for his development of propranolol and cimetidine. So isn't that fun? I just put them right together. Thank you, Sir Black. Okay, so cimetidine has actually shown significant improvement in patients with interstitial cystitis. One, maybe we're like changing that pH of the urine and making it a little more basic as opposed to so acidic. We do know that interstitial cystitis doesn't like, when your bladder's all irritated, it doesn't like high acid situation. It's like, it's an irritant, obviously. But you can use it for warts, orally for warts. So in adults who have recalcitrant warts, so you've tried everything you can do, you've frozen that thing, everything, put them on pretty high dose cimetidine and it'll go away. It works through like the IL-2 system and it actually upregulates your immune system, so you're more likely to attack it. In our HIV patients with low immune system that have significant like anogenital warts, you can always put them on cimetidine if Dr. Connell approves. It does have some receptor issues, but also in people who are on immunosuppressants for like say a renal transplant, it's actually been highly studied in those patients and not shown to decrease any of the levels of their immune modulators. So that's fun, right? Other things for warts, because I don't think I'm going to get to it at the end of the lecture, it's pretty much anything that creates an acidic or irritating environment. So when we think of a wart, we treat them by just telling your body to treat them. We do nothing to a wart when we freeze it. Y'all know that? What you're doing is you're irritating it enough and you're creating kind of like a blister situation. So your body has to come in and heal that space because that wart has been hiding, like it's been wearing its little like fake mustache and fitting in a room of men, right? And so it comes in and it's like, wait, who are you? And so it had been hiding there. You came in to heal that skin. Your body's own natural healing system is what comes in and then gets rid of the wart because it now sees it because you kind of unveiled it to the body. So if you can freeze things, but anything that creates that acidic environment. So straight up aspirin, you can put an aspirin, I mean, it's salicylic acid, right? You can put that right on a wart and tape it on, and it'll do kind of the same thing. There's other like over-the-counter stuff you can crush and put on it. Duct tape works really well. If you've ever heard the duct tape rule of like, put duct tape on the wart, it's just an irritant for the skin, and it'll come in, it'll eventually just heal itself. Low-dose naltrexone, LDN. Has anyone ever heard of low-dose naltrexone? Okay, so I don't use it a ton, but it's definitely more in my private patients. I don't know that I have any other resident patients on it. But this is the LDN book. Actually, if you go on Amazon, there are, what I could tell last night by Googling or on Amazon, just looking at LDN, is there's actually 4 different books available for purchase on Amazon, just teaching people about LDN and how to prescribe it. So this is, again, not common, but has a lot of studies and a lot of people looking into this, okay? There's actually an LDN network that has whole CME conferences just to get the word out about the studies that have been done and how it can help. So you actually have to take it to a compounding pharmacy. So I have to write it out on a script, but you just start at 3 to 4.5 milligrams, and they compound it into capsules. Because actual naltrexone is like real break-a-party, and you break it apart and it just falls apart and nobody likes that. But you have to use these micro doses of it, and it has to be given after 9 p.m. at night. And because that is when the body comes in, that's when your cortisol, overnight is starting to peak, and when you start having like endorphin releases and your body starts to heal itself. So it's actually touted as an anti-inflammatory treatment for inflammatory processes. So it's like thought of highly in the rheumatoid arthritis community as an adjunct to anti-inflammatory, and it actually increases your body's natural endorphins. So it works by a couple of ways. One, by increasing endorphins, and happy people don't really hurt, right? So yay. And then 2, and so it's been touted maybe for depression as well, but with it's binding very, very lightly those opioid receptors. And if you can down-regulate your opioid receptors, you will then start to have less pain because you're kind of binding that up and you're not upregulating them constantly with the pain receptors. So you kind of downregulate your pain receptors. Once the pain goes down, your cytokines and stuff go down, your inflammation goes down. And they're talking about like that inflammation and pain cycle person here. And this is that person that can help. You can actually just start very, very, very slow. I would even start probably lower than 3 milligrams, but you can actually start it on a patient who's on chronic opioid therapy. And over time, they are able to wean down to very low doses of their pain meds just by up titrating their LDN. Actually learned about this for the first time from a patient who came in to me who was having a hard time getting off of pain meds, and her ortho put her on naltrexone, and I was like, that doesn't make sense. Like, what? And she was like, I don't know. I just know it worked, and he was able to get me off these meds, and I was like, so that's kind of how I started looking into it. All right, finasteride. It's not just for men anymore. So when we think about finasteride, we're thinking about the 1 milligram dose for men, which is name branded as Proscar, right? And that helps with male pattern baldness. However, at higher doses, a 5 milligram, which luckily for women is the cheap version, because that's the one that you use for BPH, it is very effective for female pattern baldness. The difference between male pattern baldness and female is men usually get the thinning of the crowns here, right? And they kind of start to go back here, maybe get a patch here, and then it kind of goes around. But females more starts on the crown and spreads this way and tends to leave kind of a band of bangs here for them to like floof up as much as possible to hide whatever situation is underneath. But I think we've all seen patients with this pattern of baldness, and they say, how can you help me? Well, there's a couple other ways we can help them that we'll get into here in a minute, but 5 milligrams of finasteride might be really helpful. But remember, hair takes a long time to grow. So we're looking at 7 to 12 months of therapy before you know how effective that's gonna be for them. Valacyclovir can be used for pityriasis rosea. So the overwhelming thought is that this is a post-viral syndrome and self-resolves with time. But it could take up to a year to go away. But in the meantime, they're like scratching at themselves and they're using all the ketoconazole shampoo, trying to get rid of their terrible like ringworm infection that they think they have their back. But you can actually get symptom resolution, so the itching and irritation with it by week 2. And you can get complete rash resolution by week 4 with 1 gram TID for pityriasis rosea. Patients with recurrent erythema multiforme, they again found that the majority of patients who were having erythema multiforme had likely a herpetic infection within the months preceding that. And so putting them on 500 milligrams twice a day of Valtrex actually stopped them from having recurrent episodes of erythema multiforme. Dermatitis from patches. How many times have you given some EKG patches, right? Like how many people have like in the hospital, like you have them on the telly and they have a rash that pops up? Or a big one for me in the clinic is Clonidine patches. Oh, those are the worst. These people, I mean, like they peel off these patches after a week and like seriously like a layer of skin comes with it. It's just so awful. It's hard to get anybody to stay on a Clonidine patch for those reasons. But we're even talking about like Daytrana patches for ADHD, birth control patches, estrogen patches for postmenopausal. All of these things, they stay on for a long time and can be irritating. So a fun little trick is you can just take straight up fluticasone. You can spray it on the back of the patch and kind of let it dry, or you can just put it on the area of the skin where you're going to apply the patch, put it on, good to go. It's not oil-based, so it shouldn't decrease the amount of stickiness that that's having. But other tips are, of course, week to week, cheek to cheek, right? So if it went here, switch it to here. If your last one was here, switch it to here. You can even use, for like Clonidine patches, you can even use the upper back. You don't have to use just the chest. You can wipe the skin with some liquid Benadryl before applying a patch. Maalox actually works really well. Just a drop of Maalox kind of spread it around, and don't let it dry completely, but almost. Like it kind of gets this like really sticky, weird texture to it. At the really weird sticky texture is when you can apply the patch. One, it helps it adheres even better, and then two, helps calm down any of the irritation that would have happened. And then once they remove the patch, they can always use a little steroid cream for a couple of days afterwards, just to keep any like post-inflammation from happening. So those are some fun tricks for those patients who you really need to use something on. I mean, there are patients who really do well with medications that aren't being passed through the first pass of the liver. And in those patients, how can we help them? I think I was in a certain mood last night and I really thought this was funny. But for some reason I was like, oh, it's like lime in the coconut. So I went with it, and I might be regretting it now because none of you seem to think that's funny at all. So maybe you're all just a little too young for lime in the coconut songs. But if you have a patient who has recurrent sinusitis, and particularly thinking of that person who has those big turbinates or the big sinus polyps, right? You're like, well, you should use some fluticasone spray. And they're like, yeah, I know, I do. And they spray it, and you're like, yeah, but I know that's not going to get anywhere past here because those turbinates are bananas, right? Take the budesonide for inhalation. So send in a script for them for the budesonide. It's a Pulmicort, which you typically put in your nebulizer. Have them mix a sinus rinse like normal, like the directions say, with the packet and everything, and pour one of those 2 ml vials in there, and they're gonna get a complete sinus flush with that steroid in it, diluted just enough that it's similar to like the fluticasone spray, but it's actually getting where it needs to go. So that's a fun little trick that I think is pretty common in the ENT world. And they found that patients with large polyps, they can often avoid surgeries in those patients by reducing the size of them, or patients who are post-surgery from like getting those reduced are less likely to reform the polyps with the sinus rinses. Are we having fun yet? You guys like this? Okay, good. I'm like, I can't be the only one nerding out on like how to live life differently, right? Estrogen cream, it's not just for women anymore. Congratulations, Stan.
Sorry.
Okay, so estrogen cream has actually been used since like its conception for stopping chronic nosebleeds, and can even help at the in a really awful nosebleed situation to help stop it. So we actually have a lot of estrogen receptors in our nose. For anyone who's ever been pregnant, you would know this because you can't breathe. And the more pregnant you are, the more you can't breathe. And it's because of those estrogen receptors that are in the nasal tissues. So we can utilize that to our benefit. Unfortunately, I have never been successful at getting an estrogen cream approved for a male for intranasal use, but sometimes we'll have samples of estrogen creams. And so on men, I'll just grab a sample from the thing. And for women, you can just have them get it through their insurance. But for men, I'll just give them a sample. They don't need much, just a little bit. But then apparently some doctor out there is way smarter than me and went and made an over-the-counter version. Isn't this crazy? So some doc went and made a nasal cream called No-Bleed instead of Nosebleed. And it has soy, black cohosh, vitamin E. So they're essentially like going with those off-label estrogen receptor mechanisms, and they made an over-the-counter one for it. So that's fun. So before your next ski trip, you should start some No-Bleed before you go and be able to breathe. All right. So oftentimes we have complaints from patients, and it's generalized, non-specific complaints. It's my hair's falling out, or I'm fatigued, or I just ache all over, or it's headaches, or it's something that you believe them, but it's just so vague. So the place to start before you're going all crazy with medications and putting people on gabapentin and in an off-label use, of course, because you're comfortable doing that, remember. Consider just giving the body what it wants. So look at this person and say, but are they healthy? Does their body have everything that it needs to function normally? And then we can talk about it. I often talk about fatigue. And when we talk about fatigue, I say, fatigue is real. Lord knows I have fatigue. But until I am working out on a regular basis, at least 150 minutes a week, right? Sleeping 8 hours a day, not drinking, right? Eating better. Is there really any point in working at my fatigue? Because I need to be doing what I know I can do. So we don't always have to work things up right away, but we can do some things for patients up front while we educate them on, listen, fatigue isn't pathological until we fix the things that cause fatigue, right? So do you have sleep apnea? Are you getting sleep? Are you drinking? Are you smoking? Are you eating McDonald's for every meal? Are we, let's do the things that we know our body needs before looking and trying to treat something else. But our body needs water. Spoiler alert, it needs water. Our body is mostly water. It needs water to function. I don't even know how many patients I've had along the years who will not drink it. They won't drink water. If you're really asking your patients, do you drink water? Oh no. By the way, it doesn't look good about year 68. They really look like they're in shambles. Their bones are falling apart. Their heart disease is madness. These people are drinking pops, they're drinking sodas. Or an important question to ask is, how much water do you drink? Do you add anything to it? Because a lot of people are then taking those Neo drops or whatever, or Crystal Light packets or something, and they're actually just turning their water into something else. And they're not really getting water at all. They're actually just getting a pile of chemicals along with their water. So if they're getting dizzy, make sure they're drinking water. Any 18-year-old girl who's I just get so dizzy during the day, she's probably not drinking water. If there's a medicine resident who looks like they don't feel well, hand them a glass of water. They have not had any. But remember, water is best absorbed in the presence of a vector to help that absorption. So water is absorbed via osmosis, right, in our gut, and then it is retained or removed in our gut through retained or removed in our kidneys to eliminate excess, right? But if we don't have a good gradient there for the body, we won't have good absorption of water. So I look over and I see your hydroliter thing that I don't even know how you can drink that much and round on a normal day. But I look at that and say, are we really getting any absorption of that at all? Or is most of it just running through you? So how can we enhance that absorption? So why do we recommend some of the things that we recommend? So in order to bring in sodium into the body, it's best absorbed in the presence of glucose. So your SGLT1 receptors are the ones that are in your gut, and you best absorb sodium in the face of glucose. So not a fake Gatorade will not hydrate you. It's not sugar. It's fake sugar. If anything, it is a diuretic and causes diarrhea because it's a fake sugar. So you're actually going to become more volume depleted with a G2 fake thing. Does that make sense? So if we can get glucose in the setting of sodium in and then consume the water, we are enhancing our hydration that much more. So why does chicken soup work? Why does chicken soup make you feel better when you're sick? You're getting some protein, you're getting some sodium, you're getting some glucose, and then you're absorbing some more water with it. So you're actually hydrating more in the presence of that chicken soup. Sports drinks, why do they work? Because you hydrate more. Actually, sports drinks need to be cut in half. There's The studies have been done over and over and over since its inception that says it's too strong. So Gatorade, you should cut it in half with water and you're gonna get the maximum benefit of that. Pedialyte, that's the same thing. I'm a big fan of the old fashioned, like pop, pop, fizz, fizz, oh, what a relief it is. Like the old fashioned Alka-Seltzer. I know none of you are from the commercial watching generations because you like clearly have DVRs your whole life, but we grew up with commercials and we learned things like that. But why does the Plop Plop Fizz Fizz Alka-Seltzer work better than the little Alka-Seltzer pills? My opinion is that they're having to drink a glass of water with it and they start to feel better. And they're getting that sodium, they're getting all those little fizzy things in there, and it tastes pretty salty actually. As opposed to if you pop out 2 Alka-Seltzer pills, do this, pop your head into the sink, knock it back, and try to go to work and like, I don't know why I don't feel well, right? So you can see how if you can hydrate in the presence of a vector, that water that you're drinking right there will become a lot more beneficial to you. Body needs vitamins and minerals. Magnesium, vitamin D, B12, iron. We need all of these to feel well. What happens with nearly all of these? So magnesium, vitamin D, iron, calcium, you check blood levels and you're like, oh, their magnesium was 1.9. Well, ideally you would like that above 2, right? But the body has this funny little evolutionary mechanism that it has, and it protects the heart at all costs, because without a heart, you don't live, right? So it will steal its nutrients from everywhere else in order to survive. So your body will maintain a normal level of magnesium in the bloodstream in order to protect the heart and give it what it needs. But where is it getting that from? It's stealing it. It's stealing it from your muscles, it's stealing it from your bones, it's stealing it from your brain. So whenever we go to replete things, we have to remember that just because levels might look normal in the blood does not mean that they are normal in the tissues, which is where the patient is having the symptoms. So particularly magnesium deficiency, muscle twitches and cramps, irregular heartbeat, osteoporosis, numbness, tingling, fatigue, loss of appetite, that might be constipated, migraine headaches. I tell you what, those migraine headaches, you just give them, oh, I need to go back. You just give them some magnesium, those headaches go right away. It's amazing. But just remember, if they are running anything less than 2.0, they are deceivingly normal. These patients aren't normal. Our diets in America are severely deficient in magnesium. I promise everyone is deficient. How to replace it? So 250 or 400 milligrams a day. It can have a laxative effect on patients. So if they get that, they can just back off. There's other formulations that are fancier, like slow mag. Getting it from your food is always best. So finding those vegetables that are high in magnesium to replace it with. But did you know that you can absorb magnesium through your skin? That's why Epsom salts work. It's mag sulfate. So it works to alleviate your muscle cramps because you're giving it the magnesium it's wanting. Mind blown. So the prophylactic and abortive combination that's most common for headaches is magnesium 400 milligrams along with a super B complex vitamin and 4 cups of water in addition to whatever they normally drink. So you say, take this, drink 4 cups of water, go on about your day, but you have to at least get that in addition, and you will get rid of most headaches. B12 deficiency, remember you can't overdose on it. Low normal might still be very deficient because again, our body doesn't start showing low levels of a nutrient unless we are deficient to the point that we can no longer draw it out of the places that we need it, okay? So if we are already low, imagine how low our actual stores of that vitamin are. So more accurate markers might be checking methylmalonic acid and actually checking homocysteine levels. In a patient with high homocysteine levels, you have to worry that they might have an MTHFR mutation. I won't say out loud while being recorded what that looks like as an abbreviation. but you can imagine where my head went there. But on those patients, they actually have a mutation where they cannot methylate their B12 and their folate. So they actually would need a methylcobalamin instead. And that's easily purchased at like the grocery store. So I recommend going up and down the aisles of your grocery store to see what all is available. Vitamin D deficiency, we usually start treating vitamin D deficiency when it's less than 30, but for optimum bone health, we really need it greater than 75. So we are way under treating vitamin D. Remember that D2, the ergocalciferol that we give once a week, actually only has a half-life of a couple of days. So if you have somebody who's significantly deficient, you should start them out at 2 to 3 times a week, not once a week, because it's not going to build them up as well. But the over-the-counter D3 actually has a half-life of about 10 days. So feel confident if you want to even have them take like, seriously, like 10 pills over the counter. It's absorbed the same way. Actually, it has really great absorption. And if you find that you cannot replace someone's vitamin D, you're like, I'm giving them vitamin D, why is it not going up? It might be actually a magnesium deficiency. And until you replace their magnesium, you're never gonna get their vitamin D levels to normal ranges. Iron. So ferritin is what we need to really be measuring, okay? Because again, we are drawing this, iron is measuring your stores. So I liked this analogy that came to my head about toilet paper, of there's a difference when someone says, do you have any toilet paper? And they go, yeah. But one person has this roll on the left and another person has this roll on the right. Those two people don't even feel like they should be answering the same question in the same way, right? But technically, yeah, both of them have toilet paper. So if you have a patient, and unfortunately, ferritin is not added to our normal panel, you have to add it on. So if you're doing an iron panel, you actually have to add a ferritin on separately. But ferritin is the protein that binds up iron and shows us what our stores look like. Unfortunately, it's also an acute phase reactant. So in an acute infection, you might actually have high ferritin, or if you have somebody with an anemia of chronic disease, it might be high as well because the body is like, I want to hide all of my iron from bugs. Bugs are bad. Hide my iron. Keep it on my ferritin. So just have to keep in mind, if you've just got your normal 23-year-old coming in with kind of just some fatigue symptoms, check the ferritin levels. Our goal with ferritin levels should be above 50. And we don't get flagged that it's an abnormal unless ferritin is like less than 6. So you can imagine that we don't know that somebody's low on iron until we're here versus when we're here. But these patients, if you will replace their iron to the point that they have sufficient stores, you will get improvements in muscle pains, hair loss, nail growth, all the things that iron does. So in order to get more iron, you can take supplements. And honestly, you can even just supplement 2 to 3 times a week. Evidence has shown that doing it just 2 to 3 times a week, you get just as good of absorption and just as rapid responses as everyday dosing without as many of the GI upsets. So if you have somebody you can't really tolerate, just say, hey, back it off to just a couple times a week. And they're like, oh, thank God. And really, they are able to maintain and grow their iron levels just the same way. Have them use a cast iron skillet. It infuses your food with iron as you're cooking. But this is a lucky ironfish. Has anyone ever heard of this? So this is about this big. You can buy them. Sometimes they have sales on them online and they're like $15, but they're usually run about $30. And they're good for several years. And so you can actually infuse any food that you're eating with additional iron. So if you're boiling a pot of water for some pasta, throw your ironfish in there. And your water becomes infused with iron. Now your pasta is infused with iron. And it's easy to then add iron to all the things that you're eating. And then there's other formulations that don't hurt. So Otc Remedies, let's see how many of these we can get through. I love this meme. Has anyone tried squirting some breast milk on 2020? All right, like cramps. So we kind of already went through magnesium, we went through iron, but tonic water, has anyone ever heard of tonic water for muscle cramps? Yeah, so it's tonic water, not club soda. It actually has quinine in it, which is a drug that we used to use for leg cramps. Do you know if you put tonic water under a black light, it glows? It's fun. So you know if it's good or not. Unfortunately, if you take tonic water and you feel like you have the worst flu of your life shortly after taking it, please don't ever take it again because you have a G6PD deficiency and now you know. And the more you know, I will say that to people. I'm like, yeah, do some like 8 ounces of tonic water at night, like a little what used to be a little juice glass. But if you do get really bad flu symptoms from it, just take it again. And they just look at you and you're like, but really, it's good. Have fun. Bar of soap. Has anyone ever heard of putting a bar of soap in your bed sheets at night to help with your muscle cramps? Nobody has any idea how this works, but it's been over and over and over again proven to be true. I was even like doing my Google search on like, trying to get like studies and evidence of things because I'm trying to present evidence-based medicine here. There was even an article on Snopes about it, like the people who like debunk things, and they're like, I don't know, seems to be fine, but we just can't figure that one out, and nobody seems to be able to. But everyone says Ivory or Irish Spring. It's like kind of one of those like harsher soaps, or they're like, think of the soaps that you get at like hotel rooms, but bigger, like anything like that. People say Dove doesn't work. It's a little too moisturizing. Mustard has been proven to be helpful. A couple swigs of pickle juice. And don't forget CoQ10 supplementation, particularly in your patient with statin myalgias, because that statin is actually depleting your CoQ10 levels. So if you have a patient who can't tolerate their statin and absolutely needs to be on one, stop it, put them on 2 weeks of CoQ10 supplementation, and then try your statin again and see if you can get that relief. Neuropathy. So I know we just throw gabapentin at everything off label, but what if there's other things, one, that are cheaper, and two, have less side effects? So alpha lipoic acid can actually be bought at grocery stores. Usually the ones that are at grocery stores are like in the 120, 140 milligram dose, but you can buy at like a Sprouts or something the 600 milligram dose. And the 600 milligram dose has been shown to reduce pain, paresthesia, and numbness. I've had some pretty great relief in patients just adding that to their life and getting some relief of their paresthesias, in addition to, of course, their diabetes control. Has anyone ever heard of Metinex? So Metinex is a medical food. So it's a vitamin that your insurance won't pay for because your insurance doesn't pay for medical foods. But it is technically FDA approved. I just feel like few people know about it. And that's probably just because it's expensive. So because the insurance won't pay for it, it does cost about $60 a month, and a lot of our patients can't pay that. Good news is that they have a 90-day guarantee. So at 90 days, if you don't have relief, they'll actually give you all of your money back. But benefit is noted about the 3 to 6 month point. So you see here that they took baseline biopsies of patients' feet who were having severe diabetic neuropathy. And the one on the left is the baseline, and you see it's kind of lost architecture. They have, those nerves are dead, right? The innervation to the skin has died off. And at the 6th month, they went back and re-biopsied, and you can see that you already have even some nerve regrowth coming through there. You have some vessel regrowth coming through there. You have that beefing up. So really, maybe these patients were just terribly deficient in all the things. So Metinex is actually L-Methylfolate. And then like something that comes, it's like a phyto something that comes from seaweed, and then it has one other component to it. So, I mean, you could technically attempt to like Jimmy rig it like over the counter of something very similar. Toenails. I thought of Dr. Cook on vacation when I saw this picture. Yes, those are all part of the show today, is the sound effects. You're welcome. So toenails, Listerine soaks. So when we think about, when people are like, oh, I have a toenail fungus, and you're like, oh, I've got a med for that, and then I need to check your liver enzymes every 4 weeks, and oh, it might interact with all of your medications, and like these meds are really harsh, right? And guess what happens after you stop the medication? It comes right back. What are we doing to our people? So let's do something a little more gentle. Apple cider vinegar has great fungicidal properties to it. Vicks Vapor Rub, they actually did a study. There's been a couple studies, but the big one was actually at the VA hospital system, and they applied Vapor Rub to the toes once a day, and at 48 weeks, they even measured like who achieved complete resolution, and they had no dermatophytes found at all, and that was like 5%, but the rest of them, like all of the patients either said they were satisfied or very satisfied, and that their toenails now looked normal. So yeah, you may not have killed all of it, but you were able to kill it enough that they were able to regrow toenails that look normal now. So again, it's maintenance therapy. Listerine soaks do the same thing. I mean, it just kills kind of everything in your mouth, right? So it kind of kills everything on the toes. It's a great little like sloughing thing for your feet, but it can seep into the little crevices of your toenails. The thing is again, unless you're doing something to stop it from happening, you're gonna get it again. So that's why I said, fun fact, you now have an excuse to go shoe shopping. Because especially in women, if you're wearing your shoes without socks, you have embedded that fungus into your shoes. Your socks have it in them. And just in case you didn't know, it's very hard to kill, which is why patients have to be on long courses of medication, even if it's just for a simple like fungal infection, right? So you washing your socks on hot in the washing machine is not going to be enough to kill them. So I usually recommend that once we start to clear up the infection, you notice that the toenails start to look better, throw away your socks, go to Walmart, buy a new pack, and start over. And ideally, I would recommend even just getting all new socks every 6 months. Just keep changing them out, because you're never going to get rid of it because you keep using the same socks from 3 years ago. P.S. They're infested.
You actually talking to a patient once about this in the clinic. Have you found, does it matter if you actually go to a podiatrist or whoever and have the toenail move, or is it?
So I wouldn't remove a toenail. I mean, again, you don't do a procedure that doesn't need to be done, but I wouldn't remove a toenail unless it's like ingrowing and they're getting like a true infection. If anything, I don't know if you've ever tried to remove a gross ooh toenail, but that thing like falls apart. Like it's like, yeah. Yeah, but I mean, if it's all the way deep down in there, I mean that, or you could probably even try to like go and take a Dremel and take the top layer off so it can penetrate. I mean, all right. I'll try to get a couple more in. So cerumen impactions, pop a colase in that ear. There was a study done in emergency departments, and if you have any just colase sitting around that you've used for your constipation, pop it, squeeze it in the ear, let it sit there 5 to 10 minutes. That sucker slides right out. It actually had way better results than your traditional medications used to break up cerumen. 86% versus 35%. And depression, I need to fix some of these. I did it on my Mac, and clearly that doesn't translate to a real computer anymore. So depression, use a sad light. Have you ever heard of a sad light? So a light meant for seasonal affective disorder. So these people like, I mean, I totally get it in the clinic at the risk of being TMI, which I'm never a TMI, but in the clinic, we're there all day long, and like, especially in the winter, but we're on the north side of the building. We never get any sunlight at all. I'll tell you, like when we moved over here to the POB for a little while, I was like, I'm so happy. I have so much energy. And it was because there was like sunlight coming into my life. And apparently I had not had any in 3 years. So it affects your mood. So I got a sad light to put at my desk in the winter. It has to be at least 10,000 lux. You can buy them from everything from several $100s to a $39 one on Amazon. Ideally within the first hour of waking up in the morning, but you can use it up until like 2 p.m. But I promise if you use something beyond 2 p.m., you're gonna be up all night long. And you leave it on for about 20 to 30 minutes, and you just have to have your eyes open and in the direction of the light. You never wanna look at it directly. It's too strong, it'll give you a headache. But like I had mine right underneath my computer screens, and people would come over, and I think like everyone's like bugs. Like they're like, ooh, what's that light? I'm like, don't look into it. It's my light for my depression. Don't look into it. And nobody can help themselves. They're like, what is this light? I'm like, everyone's like little like mosquitoes wanting to go to the light. All right, L-Methylfolate, which we kind of already talked about with, that is included in the Metinex. But L-Methylfolate is the methylated version of folate. So it is your activated version of folate. And the studies were done at the 15 milligram dose. There is a prescription version of this, but it's about $60 a month. But you can buy it online, and like really good high quality L-Methylfolate you can get for about $75 for a 90-day supply. So we're still looking at less than $1 a day. The studies were all done on patients who were already on SSRIs or SNRIs, and L-Methylfolate actually increases neurotransmitter release across the synapses. So you already are on an SSRI, so it's stopping that reabsorption of your serotonin, your norepinephrine, but this is increasing the release of your serotonin and norepinephrine to make it that much more effective. I will sometimes use it without the presence of a medication, but it is considered add-on therapy use to help make that SSRI or SNRI more effective without an increase in the side effect potential of the medication. But of pretty good studies, they've shown up to 54% of participants have resolution or remission of their depression. So that's pretty good for just adding on a vitamin to their already regimen, as opposed to adding on multiple meds or increasing doses or all the things. And actually some recent trials have shown improvement in schizophrenia. And I'm going to stop there because apple cider vinegar is too big for us to take on right now. Any questions? Okay, awesome. Thank you. Oh, how did I stop record? Oh, recording.